on
This meeting is being recorded.
at the OTP Oklahoma City VA for the last 3 years. And so I just want to welcome everyone. I'm really looking forward to today's presentation. And I will turn it over to them and we'll put all the recording business in the chat. And thank you and welcome, Erin.
Thank you. And yeah, so I worked in STAR, which I worked part in the OTP within STAR at the VA for a little over 8 years. And then I sent it to Kelsey, but it was kind of last minute. But I've transitioned to another program within the VA. So I just wanted to throw that in there. But I thought this topic would be important because I know a lot of times it's not talked about or not presented on. And so Dr. Snyder kindly offered to join me. I think he offered yesterday, maybe the day before. So what we're going to do is co-present and just kind of feed off of, what each other's saying and just laid back, that sort of thing. So Dr. Snyder, do you have anything you want to add?
No, I just agree with you that I think it's a really important topic that doesn't get a whole lot of discussion. I don't know how many people I've talked to about this patient-wise that say, I wish I knew about this sooner. It saved my life. I wish I would have done this years ago. So I think just having a little bit of exposure to it, it may save lives.
For sure. Okay. Dr. Snyder, do you want to go ahead and control the slides?
Sure.
Okay, so what we're going to do, and it dawned on me as I was driving today that, I put in the title, Introduction to Methadone Maintenance Treatment. I should have put for opioid use disorders. But anyway, we're going to provide an introduction to that, explain, what it does, why it's important or why it's effective, biopsychosocial parts of it. Hopefully this will increase awareness of methadone maintenance. And we also want to shed some light on the opioid treatment program within the Oklahoma City VA that, like Dr. Snyder was saying, a lot of our veterans didn't even know it was there. And then really present or really identify that opiate or opioid addiction is a medical disorder. Okay, so I'm sure we know of common opiates and opioids. Here's a list of them. I'm sure most of us have heard them or have heard street names for them. I'm just providing a list there. And we know, I'm sure you've heard a lot about fentanyl.
And these are really, really common medications. I think if you've ever had a surgery or really any kind of acute medically painful condition, there's even a likelihood that we as individuals could have been prescribed some of these. When we talk about recovery from them, I think, maybe the top one up here, heroin and fentanyl right now gets so much attention on them, rightfully so. But there's the opioid epidemic kind of has taken place because of all the excessive prescriptions, and it's kind of led down this path as well. So that just the ones that you can get from your medical doctor are presented here in just as equal footing.
Right. And so this is just a picture to show areas of the brain that opiates act on and how the types of changes it makes. So such as the brainstem, opioids impact that and make changes to that once they're ingested. And that controls basic, CNS, our basic functions, coordination, heart rate, reflexes, regulates our breathing. So just basic functioning. Opioids, once ingested, they do affect that and can change the functioning in those areas. Also, the limbic system, we know that from other substances, how it changes emotions, and we're creating the euphoria. And then, as it states on there, opiates can block pain messages transmitted by the spinal cord from the injury, hence why they're effective, right? Though short term. Okay, so the effect, so endogenous opioids, like we equate that to endorphins. So like naturally producing inside your body and your brain already. It's not something, a substance that you ingest that then increases the dopamine. So what kind of things increase or release endorphins or increase dopamine in our brains is stuff like exercise, spending times with friends, sometimes it can be eating, it can be sex, those kinds of things. With the exogenous, I have trouble pronouncing that word. That's when it's like heroin, alcohol, any kind of drugs. It's something that you're putting in your body that significantly increases your dopamine. So it's an excess. So it's hence why people can become addicted or dependent on those. So depending on the amount of the increase, or depending on the dopamine increase, or depending on maybe the psychosocial issues in conjunction with that, or depending on a lot of things, some people can become more easily addicted, others may than others, and some may not become addicted at all. I once read, it was years ago, and it was through SAMHSA, and it said that alcohol increases dopamine by 130%, that heroin increases it by 170%, and then methamphetamine increases it by 1100%. So I don't know, that's always stuck with me, but I always found that it's fascinating. Can explain though why they are addictive. So Dr. Snyder, you have anything you want to add? And just feel free to jump in there.
Yeah, and one of the reasons why these substances work, even though a lot of them are man-made substances, is because we already have these receptors in our brain, because our body naturally produces some of the, or variants of these chemicals, like Aaron was talking about. Endogenous means, in our body. So we have these receptors in our brain already to block pain, to do all those things. The exogenous ones are, they come from outside of our body, external to our body. Those man-made chemicals, or, at least ones that don't come from our own body's production, are so much better at doing some of these things. But it really is no question why people can get addicted to them, because the effect is so far and above what our body can naturally produce anyway. So the pain relieving effects of an opioid painkiller are just so far away and above what our body can naturally produce. It makes a very effective medical treatment. However, it's that is also something that can become a very highly abusable substance. Think of Aaron, you mentioned the 1100% above and beyond what our body would naturally produce of dopamine as a result of methamphetamine abuse. And that's an incredibly high amount. And then people kind of get addicted, at least partially, to that piece of the effect. Not to mention with opioids, withdrawal tends to be something that keeps people in that process, even when they want to quit.
Right, for sure. Okay, so this is from SAMHSA, and SAMHSA has, I'm sure some of you are aware of their treatment improvement protocol tips, and they have a tip 43 all about this information presenting about methadone and treatment for opioid use disorders, types of treatment available, not just methadone, but other medications. So in general, they say the person has to be currently addicted within the past, with continuous use of at least 1 year. So we thought Dr. Snyder and I were just talking about that prior to starting the presentation, and I thought that was a little bit interesting that why does it have to be a year? Because you could have all those adverse effects, within a month or two. So except for persons that have been incarcerated, which makes sense, right? So say they're incarcerated, they're off, I've heard of one, some smaller jail, and they prescribed one of my veterans Suboxone, but most often they don't prescribe a medication assisted treatment. So I had a veteran, I had worked with him for years, young guy, try not to have favorites, but he was one of my favorites. He was on methadone, fairly stable, young, kind of not always making the best decisions. And he ended up getting some legal trouble, and he was incarcerated, and he was in the Oklahoma County Jail. Well, I used to work part-time on the weekends at the county jail in mental health. And one time I was on a pod, and it was the last time I ever saw him. And he was coming out to get his meds, and he's like, "Hey, Aaron." And I'm like, "How are you doing?" And he's like, "I'm good." Well, he had already withdrawn off the methadone and had been off of it for 4 months when he was released from the jail. And then it was a matter of, I think, 1 or 2 days that he overdosed and died. So that part, is a significant thing to remember of. And, I kick myself because man, I wish I had called him. I should have called. And I didn't know when he got released until it was way after the fact. But being able to gradually get them back on the methadone after they've been off of it for a period of time, for something that wasn't in their control. Documented indication of past addiction. So this can be medical records. It can be UAs. You can look up on the PMPs and see, prescriptions that they have received. It can be lab work. It can be consultations with the patient. Sometimes it can be getting collateral information from loved ones. All of that kind of stuff. Just some, well-rounded documentation. And then withdrawal symptoms. So we'll talk about that in a little bit. We'll talk about subjective withdrawal symptoms versus objective withdrawal symptoms, but they do that assessment, the nurse, the doctor, and as veterans continue to work with their therapists within the program, and may need, dose increases, oftentimes the SOWS is administered. And we'll show you what those look like.
Yeah, and I think one reason some of these eligibility criteria, or at least considerations exist, is to differentiate somebody that is, maybe taking their prescription opioid pain medications in a reliable way, in a way that they're supposed to be taking it, that may not, they may be physically dependent on that medication, but they may not necessarily have an addiction to it. So if a physician says, that I no longer want to prescribe you opioid pain medications, and immediately withdraw that, which would not be particularly great practice. Of course, they're going to go into withdrawal, things like that, because their body's physically dependent on it, but they're not necessarily, they don't necessarily have an addiction to that. So the diagnosis of an opioid use disorder is a very important piece of this. I had another thought, but it vanished into thin air. Happy Friday, everybody.
It'll come back to you Friday afternoon. So, okay. So medications approved by the FDA for medication assisted treatment. There is I know there's methadone, Suboxone or buprenorphine, Vivitrol, naltrexone. There may be others, but I'm not for sure.
That is all three.
What is it?
That is all three.
Oh, okay. And then, so induction onto methadone has to be medically supervised. So I know that within the VA, they'll have to come to the clinic in the morning, they'll start them on a certain dose, and then they'll have them hang out and continue to kind of monitor them throughout the day. And this could be a period of a couple days. Typically it's, you check for the symptoms, whether, withdrawal, whether it's objective or subjective or both, before you administer it, and then again in 30 minutes after administration, and then again in 2 hours. And they check, blood pressure, that kind of thing. They do thorough medical history, physical exam. They do EKGs, get lab work, all this kind of stuff they do, prior to starting methadone or being approved to be on methadone. And then, of course, there's a psychosocial assessment provided by the therapist, and that comes after, at least within the VA opioid treatment program. When I was doing it, that psychosocial assessment comes after they have been admitted to the clinic and started on the methadone. And then provide education to the veteran about methadone, whether that's, pamphlets, verbal, education, a number of things. And then making sure they have a commitment and a desire to participate in a program that's very structured and it's intensive. So a lot of times people can struggle with that component of it, because when you first start within the VA, when you first start dosing, you have to come up there every morning, and it's in a certain window of time. If you miss your dose, if you don't get there in time, then you don't get your dose. There's a group requirement to meet with your therapist, or in STAR, the OTP, we'll call it recovery coordinators. So it's a commitment, and some struggle with that. So just really considering that. I know I've heard from veterans that we had that transferred to our OTP from methadone programs within the community. I think some of them have similar requirements, but some of them don't. I'm not, based on what they've told me, just because when they came, they're like, oh, we didn't have to do groups, or, oh, we didn't, we only had to meet with our provider once every few months, or stuff like that. So it's an intensive program. It's a commitment. It's a medication that, we've talked about physiologically and psychologically impacts you. And so if it's just you're taking it, and then all of a sudden, I don't want to do that anymore or whatnot, if you just stop taking it, they're going to have all those withdrawal symptoms. So it's a commitment.
Yeah, and that's a really big piece of it, is that it is more than simply taking some medicine in the morning. And the medication alone does an awful lot of the heavy lifting in terms of keeping people out of withdrawal, keeping cravings at bay. That is some of the two biggest reasons why people relapse. However, that just having those things taken care of does not impact, or doesn't treat the other things that may be going on for the person. The addictive thinking and behaviors that develop aren't suddenly solved magically because craving is gone or because they're out of withdrawal. Working with in a therapy program in addition to that really is the key. And it is an intensive thing, and it's designed to be intensive because intensive treatment is necessary at times. That comes with challenges. I think, Aaron, you hit on a lot of them that come up primarily. But it's a federally controlled medication. In the beginning, to suddenly hand out a large amount of a controlled narcotic would not be a very good idea. That's part of the intensity, that in the beginning you have to work your way up to feel confident in your own abilities to be able to handle that kind of medication at home without additional supervision. And we'll get into a lot of what that looks like practically, I think, a little later. So I can go ahead and just keep on going with it. So methadone is considered a full opioid agonist. Suboxone is another a medication for opioid use disorder that's considered a partial opioid agonist. And the way I kind of view the difference between this is a partial opioid agonist, even if you're at the highest dose, still won't completely 100% fill all of those opioid receptors. So it's going to do a really good job of quieting and turning the volume down on a lot of the things like withdrawal and cravings and things like that, but it still doesn't fully capture all of the receptors we have in our brain, whereas something like methadone, which is a full opioid agonist, does, which is that's a benefit. Not everybody necessarily needs that to be successful. However, that can be a turning point if something like Suboxone, Subutex, buprenorphine is not an effective treatment for that individual. Anecdotally, this may be one reason why, I get reports that for folks that are struggling with fentanyl as a part of their addiction, that Suboxone, at least for some people, doesn't seem to be as effective, especially initially, whereas methadone can be. It's very likely the difference between those two in this way. Dosing, at least as a part of an opioid treatment program with methadone, happens once daily, as a little different than, well, in most cases, and so I'll put an asterisk next to that. In most cases, you take it at the same time every single day, usually in the morning, and it lasts the entire day at its optimally effective dose. That is different than most abusable opioids that people are using, fentanyl, heroin, or their prescription opioid painkillers. Those medications are very short acting. Within 3 or 4 hours, or you'll need to be taking another one to get that dosage back up again. And that's one reason why this is such an effective medication, is because it gives that same or a steady level for an entire day. So people don't have to be going out immediately, run that effect kind of crash and be looking for their next fix of it. It's something, so it's stable, it's consistent, and that really gives people a different level of functioning when they don't have to be worrying about that all day.
Mm-hmm. Right. And I think that this is often what we look at as providers when we're working in the substance use disorder field or addiction field. So methadone was established, and I think this is on another slide, as a treatment in 1964. I believe it was 1964. The American Medical Association stated alcoholism was a medical or medical condition, disease of the brain in 1964. And then in 1987, the American Medical Association identified that other substances and drugs are a brain disorder or disease of the brain. And then in 2011, ASAM joined kind of with what the AMA was saying, stating that, addiction, it's basically, it is the disease of the brain. It's not something about making poor choices or, poor morals, that kind of thing. And then, it's compared to other diseases, how other diseases can change the structure or functioning of the organ, of whatever that body organ is. It's considered disease, the organ is, and that's considered a disease. So the brain is the same. Chronic substance use changes the structure and functioning of the brain. Therefore, it's considered diseased. So we may have different opinions on it, and that, I know even with the addiction field, providers can have different opinions. But I think, all that stigma related to, these behaviors that are manifesting from this substance use are usually pretty ugly. So this person is a bad person, or, they just don't know how to follow the rules or laws, or, they have a bad character, when we know that that's not the case most often. So, And once taking enough of it, I think Stephen kind of touched on it with heroin or opioids. I mean, once you take enough of it, withdrawal, I've had so many veterans tell me it's like, I feel, once they no longer have access to it or withdrawing, whatever that opioid was, they say, I feel like I'm dying. I feel like I'm dying. I know I'm not dying, but I want to die. So it's incredibly intense. So then it does.
Go
ahead.
As it relates to kind of this question at the top is, addiction a medical or a moral problem? You've touched on it, just from opioid use disorder, but even within using methadone versus not using, a medically assisted treatment, there's a lot of stigma that comes even from that. Even within professional circles, there is stigma involved around this medication in particular. It's been around a long time. It has some degree of reputation to it. I'm sure folks that have worked around it in some way, shape, or form have heard some of those things, and that trickles down into the potential consumers of this. That their families may have certain opinions about them being on methadone as a part of their recovery. Their friends might, other people that they're associated with in their addiction might. People in their 12-step meetings may even have strong opinions. There are some 12-step fellowships that don't agree that using a medication-assisted treatment is considered recovery. So there's a lot of avenues that this comes to, but at least for Aaron and I and other folks that work with this very specifically, we absolutely see methadone or whatever other medicine for medically assisted treatment to be a very helpful life-saving tool. But if you ever get a chance to work in this kind of area, you will absolutely run into stigma that our veterans or patients face simply because of the medication that they're on.
I've had people that when I was in the program, they're like, methadone, was that meth? It's like, no, it's not meth, it's not amphetamine. But yeah, and the veterans struggle with that, the stigmatizing or the blaming or the shaming, and oftentimes they themselves don't necessarily want to be on methadone, so they'll already be kind of shaming themselves. So working through a lot of that. A lot of times, family, like Stephen said, I had a veteran that I had worked with him, it was in the fall, several years ago. He was a young guy too, and his parents did not want him to be on methadone, and he was using heroin regularly. And they did not want him to be on Suboxone. He also tried to go to a sober living place, and they would not allow him to be on methadone or Suboxone. So I lost contact with him, and then last I heard, he had overdosed and died on New Year's Eve. So it just, I mean, I can understand people having maybe a gut reaction to something, but I think getting the education on it is important too. And then I've had people that their significant others or families were against it, but once they saw how well they were doing, they became supportive of it. Okay, so I had said that methadone maintenance treatment was established in 1964. SAMHSA considers it the gold standard of treatment for opioid dependence or significant opioid use disorder. We know that abstinence only when someone has developed that, particularly, the psychological, yes, but particularly that physiological dependency on it is not effective. So just saying, well, just don't use, or, do all these meetings, and they're experiencing not just psychological, but all these physiological symptoms. That doesn't mean they could be on a maintenance treatment forever. But as far as treating it initially and for the foreseeable future. It's a long-acting medication, and Stephen had talked to, and it says in one of the slides, the as an analgesic effect of 6 hours, a half-life of up to 90 hours. And it's used for 2 different things within an OTP, and that's detox or it's for treatment for the opioid use disorder. Methadone is prescribed for pain. Some doctors do prescribe it for pain, but that's done outside of an OTP. It's not regulated by CMSA, all that. OTPs are regulated by CMSA. You have a lot of criteria you have to adhere to. So yes, okay.
Yeah, and I think you touched on everything on here without, I think you're psychic, Erin, or you've given a talk like this before. But yeah, an opioid treatment program is a very specific kind of treatment facility. It is separately accredited from a lot of other things. It has inspections that occur every so often. I know we're getting prepared for one this year. They are very specific kind of things. And Erin, you're absolutely right that pain management is not the focus. If that is the case, they are referred to some other clinic that can better help them with pain management. However, I think a side effect of the medication is pain relief in a lot of cases. Somebody's methadone dose is considered based on how it is getting rid of their withdrawal symptoms and their cravings. So that actual dosage number may not be the number that completely removes pain from them. They may need additional support from a pain management team in addition to this.
Right.
The next is kind of an interesting thing. It is very, very, very common for extended time on opiates for people to have a much lower pain tolerance than they used to. That is, I think that helps create a very cyclical reliance on opioids for people that I took opioids for pain. Now when I'm trying to stop my pain, is this so much worse? Now I better get on opioids again. That's just kind of a catch-22 there. And of course, like I said, it's kind of a trouble we run into an awful lot of time, that somebody sees in somebody's medical record, oh, you're on methadone. That means you have your pain medication. You don't need anything. However, because it's being prescribed for an addiction rather than for pain, that simply may not be sufficient for that purpose. If it's within a centralized system like the VA is, that's a little easier to manage. If it's from an outside community-based setting, that discussions may need to take place to clarify exactly what that medicine is being used for.
Yeah, and I was just going to say that, they can be prescribed some pain medication while on methadone. So say, some surgery or, something, they're hospitalized for something. And what often would happen within the VA is one of the psychiatrists, prescribing psychiatrists of the methadone, would contact the provider caring for the veteran within the hospital and say, hey, it's okay to, do this. This is the dose they were on, and that sort of thing. So it is okay, but just like Dr. Snyder was saying, that it does happen frequently. I've had so many veterans tell me that, I had one veteran break his wrist and his provider would not give him any kind of pain medication for it. So yeah.
Just physically in a setting like a methadone treatment center, the methadone will come in the form of a liquid. It smells just like cherry cough syrup. It is not a very pleasant thing, but that's the form it comes in, because that is a diversion control mechanism. It is harder to cheek a liquid medication. You can get somebody to start talking after they are supposed to dose to make sure they've actually swallowed it. And with new pumping devices to pump the liquid and dispense it, you can get very, very, very small to the single milligram dosage amounts in there. So it can also be very reliable in that form. Now, tablets can be prescribed, and their doses, that's usually what you would see if somebody were being prescribed that for pain. Those come in, at least here, in 10 milligram tablets, and would be, somebody's inpatient at a hospital unexpectedly. That's usually what that would look like to continue. But the liquid form is a kind of a unique modality used in addiction treatment centers. It's very interesting to talk with somebody that's recently been to, they had to have their gallbladder out or pancreatitis hit and they had to go to the hospital. They gave me my methadone while I was up there. It was 15 little pills that I had to take because they only come in so, in tiny little increments.
I think it's 10 milligrams.
Some treatment centers use buprenorphine instead of methadone for their treatment. It is a very effective treatment as well, but that can come in films that you dissolve under your tongue or little discs that can do the same. Again, the purpose of all that is it's in a different form to offer an additional protection against that medicine being used for anything other than what it's intended to. So once people take it, there's not this additional risk that it's getting out into the community, or we're trying. It's going to lessen that. I don't know if that risk can ever be completely zero.
Yeah, and the VA does, within the substance treatment program, also prescribe Suboxone, and Suboxone may, work better for some. It's when somebody maybe isn't as heavy of a opioid use disorder or has shown maybe some ability to be able to take the medication as prescribed. Because within the STAR program, when they first start Suboxone, they get a 7-day supply. They don't do daily dosing of Suboxone. So if someone was really struggling, they might have a problem with, not taking them all at once, or maybe even selling, that sort of thing. So methadone maintenance is, or OTPs are suitable for people that need more structure and intensive treatment. And respond better to, and if they respond better to a full opioid agonist. Because I've had some people tell me that they've done methadone or they've done Suboxone, maybe Suboxone first, then that didn't work well for them, so they did methadone first, and they wanted to get off that, they did Suboxone. So it kind of depends how they respond to it as well. So tip 43 talks about this. A lot of times people are, afraid because, I'm taking this and I'm taking it daily, and what kind of side effects could it have? And SAMHSA, through their research, said it has very few side effects. Sometimes they also worry about it causing medical problems. According to the tip 43, there was no research to really support that. It's hard to differentiate that because some people may have chronic medical problems and they just didn't treat them, or they were underlying, and then they come into the methadone program, the OTP, and they get, start to feeling better. Maybe they start going to the doctor and find out, oh, they have this and that. Well, it doesn't mean that it is caused by the methadone. Most common side effects that we would hear often, or I would hear, is constipation, sweating, and decreased libido. I know that's been something that a lot of the veterans have struggled with. And there's some other, with trouble sleeping, waking up early and not being able to go back to sleep. So it's also, you have some of these side effects. So you have to take that into account too, that, okay, can I deal with these? And often, those side effects are much better to deal with than the alternative of, being addicted, having to use a substance regularly.
Yeah, and a lot of the side effects that are typically seen are more of inconveniences more than they are, lasting, dangerous potentials there. Methadone can extend the QTC interval, so that had, that's why a physician is involved in this, of course, for monitoring if somebody has something like that or is on other medications that would also have that effect. But in general, you're absolutely right. So I'm looking at um, the list of possible side effects of this right now. It's, like weakness, loss of energy, chills, hot flashes, weight gain, constipation, dry mouth, nausea, joint pain, anxiety, headache, decreased sex drive, insomnia, things like that. So we're not seeing things like long-term impacts on your liver, long-term impacts on your kidneys, anything like that. So that, it's been studied for a long time. It started out in the 60s and we're in 2023 today. It's been well established as a safe and effective medication to take even long term.
Mm-hmm. Yeah. Yeah, they're veterans, right? And Stephen, or I'm so used to calling Dr. Snyder Stephen because I worked across the hall from him, and that's how. But there's been veterans in I know in the methadone program for decades. So.
Correct. I have more than a handful that have been using this medication successfully for 20 years or more. And that's there's always a question there of, what should the goal of treatment be? Should it be to eventually have used this as a very productive tool and then eventually taper off and be able to, quote unquote, stand on your own 2 feet? Or is that, just expect to be on this for life? And I believe that's just a very individual decision. We'll get to a little bit of research in later slides that I would share with somebody, but it's always going to be their decision. And if they eventually want off of this, what do we need to be doing to prepare somebody for that? But there are some medications, and I'm not going to quiz anybody here at the end on a whole list of these. It is important for folks to know that there are certain medications that just do not play well with methadone. The list is here. A lot of these will initiate withdrawal almost immediately. You can probably see Narcan on here. That's its intended effect. But there are a lot of others that if you mix them together, people are going to essentially go into withdrawal immediately. And that is very, very unpleasant. And so these are definitely ones that people want to avoid completely. So you can see that now Trexone, which is Narcan's on here, but also buprenorphine is on here. Well, naloxone is Narcan. Now Trexone's the other medication. So I always get those backwards given how close together they sound. But it is, you should not be mixing methadone and other MATs at the same time. They just, together, they don't play very nicely.
Right, right. And one other thing, we didn't put a slide on it, but about Narcan or naloxone. So each veteran in the OTP is administered or given at least one supply or dose of Narcan to keep, on them or keep at home. Sometimes they want a couple more. Sometimes they want some in case, an associate or acquaintance overdoses. And then trying to make sure those, once they expire, keep on top of that to make sure they get a new one.
Mm-hmm. Yeah, and that's, I think that is standard practice with opioid prescriptions, and at least the VA right now has expanded that to include stimulant. Anybody that has a stimulant use disorder will be essentially flagged to have a Narcan kit, given the amount of overdose deaths and people with a stimulant disorder related to opiates. That stuff is being cut with fentanyl so frequently and commonly. Let's see.
Right. Okay. And then cognizant of the time, Dr. Snyder. So do you want to talk about this a little bit, peak and trough?
Yeah, I'll be quick with it. So there is a kind of we're looking for the optimal dose when we're prescribing somebody this medication. So we do not want to be going into this category over here where somebody is over medicated where, you know, they're nodding off, they're over sedated, their respiratory system is being depressed. They're essentially, in a certain way, these are symptoms of, you know, being high on an opiate. We do not want them to be over medicated. We don't want them to be in withdrawal. If that is the case, people are going to be seeking out relief from that. We want to be in this comfort zone here. For methadone, what makes it very, very effective is this time scale down here. So we reach the peak of its effectiveness, or the maximum amount that's going to be in somebody's bloodstream at any given time, early on, just within a couple of hours. And then it will last and keep people out of this other withdrawal category throughout a 24-hour and oftentimes longer than that period. And this is what makes that so effective, is that this gradual process is gradual. This is just another way to look at this, and it introduces this other line of what would happen with something like heroin. You know, this time scale at the bottom is the same, 0 to 24 hours, where methadone will keep people out of the category where they're experiencing withdrawal symptoms for an entire day or more. Heroin will produce a very immediate high, and then that tapers off very, very quickly. So where methadone within the first couple of hours is reaching its, you know, full effectiveness, heroin's also already putting people into not only just discomfort in their withdrawal, but severe withdrawal symptoms, where, you know, this is where the people are saying, this is such a bad experience physically that I feel like I'm dying. If I don't get something else, my body is telling me I'm going to die. And we look for withdrawal is an important piece of this. We want to keep people out of that just because of how influential staying out of withdrawal is to people relapsing. There are scales involved with this. The one a physician or a nurse might go through is called the Clinical Opiate Withdrawal Scale, or COWS, which is kind of a fun name, makes it easy to remember. It looks at, especially in induction, this is used to determine what level of dose somebody would need initially. So if somebody's, you know, in mild withdrawal after a certain period of time, they may start out at a lower dose. We don't want to overdose them at first, but if, you know, somebody is in that severe stage in that short amount of time, that may need to be increased for that to be effective.
And then included, there a link to the cows and the sows. And
do we want to pull those up to show them, or do we want to skip this for now?
Yeah, we can say it. I mean, you know, like Steve or Dr. Snyder, said, cows easy to remember, sows easy to remember. So cows is, like he said, usually administered by the doctor or the nurse, looking for the objectives. Withdrawal symptoms, dilated pupils, sweating, inability to sit still, goose flesh. And then the sows, usually administered by the therapist or recovery coordinator. And that's the, you know, the psychological stuff that they're experiencing. Because that may indicate, if they're with the sows or cows, may indicate, though, or both can indicate if they need a dose increase.
Yeah, and yeah, as you can imagine, there very well could be differences in those scores. So the cows looks more at, you know, the tangible stuff that somebody may be able to observe in an assessment. So and somebody's subjective experience of, you know, their withdrawal may be something very different than that. So where you can physically see whether somebody's pupils are different or not, or whether their skin literally has goose flesh on it or not, or if they're shaking or tremulating very, very severely. The sows would, you know, ask the person experiencing it, you know, essentially on a scale of 0 to 4, how intense are these symptoms for you? Now, I've also had it where people say, you know, all 4s all the way down for everything, but, you know, they're sitting there in the chair, perfectly calm, and, you know, maybe tapping their foot a little bit, things like that. You know, that's, you there may be some questions on there. So that's why there is a difference between the two. In terms of finding that optimal dose, nobody is really exactly the same on that. I mean, that makes sense. That's pretty much just, you hear that for pretty much any medication, that we're all different. It's going to be different from everybody for the most part, but somewhere between 80 and 120 is for the majority of people a very good stable amount. Some people can, get that initial dose of 30 milligrams and, that suits them just fine. Some people, just depending on maybe the intensity of their addiction, how much heroin or fentanyl they were taking, may need, at least in the beginning, a higher amount than that to stabilize. So it's just going to depend on the person. There aren't caps or anything like that. So there's not some sort of committee decided upon maximum dosage of that. But for the most part, most people will be treated effectively at 120 milligrams or lower. So the criteria for looking for that, of course, is withdrawal is taken care of for at least 24 hours. Craving is, people aren't just having that psychological seeking of that behavior as strongly anymore. Euphoria is not being gained, even if additional drugs are being supplied extracurricularly. So the euphoria, because all those receptors are blocked by the methadone, the euphoria just isn't happening anymore. Even at an optimal dose, sometimes methadone can be sedating if there's an increase to it. So it can take a little bit of time for the body to adjust to that and that sedative effect to essentially equalize or normalize. And even within, the first hour or two, some people may say, yeah, I get a little sleepy right at first. It's not, I know that's coming. I know how to handle that. Usually when it's at the optimally effective dose, it's not so severe that somebody can't operate a motor vehicle or anything like that. But that would be a sign, if that continues to happen, that a dose may need to be reduced. We want people to be able to live their life safely. And of course, having a good side effect for most people that experience pain is that it will have an analgesic effect. We call that a side effect because the main effect right now, at least for people in these kind of programs, is treatment of withdrawal and cravings.
And it's just a little, I think we're almost done here, or we're running short on time. Just showing the factors that can go into whether somebody is going to get on methadone, whether they decide to do that. So the patient or veteran's own psychological and physical issues, then sometimes that's accompanied, societal stigma, which I talked about earlier, can sway them, or family being against it can sway them. There's several factors that go into it. And then once they're on it, how they feel about their dose, if they, sometimes they, may gradually need an increase till they get to that optimal dose. Do they feel like they're on too much? Do they feel like they're on too little? I've had several veterans that were like, no, I just want to stay at 70, but then would continue to struggle. But there was very much in their mind that they didn't want to go any higher than that. So being able to be flexible with them and work with them is really important. It's a collaborative, just like other treatment that we do. Okay, but relapse and death. They sometimes I think I mentioned, sometimes I've had several veterans go to like primary care and like the provider said, when are you going to get off methadone? You get off methadone. Or they go to the ER, when are you getting off methadone? So sometimes they can feel that pressure from their provider. That could also lead them to not going higher in their doses, wanting to stay at a certain amount. And then here's just a statistic. It said that for those that detoxed off or opiates or methadone, 80% resumed daily use. And I had a veteran a long time ago, he detoxed and he did really well. Then I had some that they either struggled right away or gradually struggled. And then the more time away from it, the higher percentage of relapse. High risk of, so if they're on methadone, oh, go ahead.
I was saying this was the statistic I was referring to, when I was, saying what's the end goal for somebody on this kind of treatment? Is it to taper off or is it to stay on it? The long-term outcomes show that the most common result of coming off of a treatment like this is that people, relapse and have to come back to it. And that's an important thing, that to me, it really just highlights how powerful of an addiction this is. And, for most other substances, we don't have a medicine that can, take care of withdrawal and cravings, things like this. This is such an effective kind of thing. And I know most people would, that are addicted to other substances would love to have a pill they could take or something they could swallow every morning. That kind of relieves all of these different struggles that they're having to deal with. But it does really emphasize the importance that, this is a treatment. You may be on insulin for the rest of your life. You may be on an albuterol inhaler the rest of your life. We don't criticize that. We don't tell people, well, when you're going to start walking more so you can get off of albuterol or anything like that. I can kind of giggle about that a little bit because it's a little ridiculous to think like that in some ways. But that there is pressure to that, and that can have very real consequences for people. Even if the decision is ultimately theirs, that kind of pressure from physicians, from family members, from peers to say that no, you're not really in recovery, or it's some alternative drug you're replacing your addiction with, leads to unfortunate consequences.
Yeah, it's shown to be, or do we want to skip? One thing I just wanted to say real quick is that, I had a lot of veterans that once, went from severe opioid use disorders to getting on methadone, to getting some stability and completely transformed. There's several that became full-time employees at the VA, got families, got their own businesses. I mean, all kinds of stuff. So, methadone, while it has some of these side effects and can be sedating, it's the effect that it has physiologically, as far as the symptoms, and psychologically, as far as cravings, it is amazing. I've seen it's really cool to see that transformation.
Yeah, and I know that we are just after 3 o'clock, and we're approaching 3:05 actually. Yep. So I know Erin and I have talked a lot about how this relates to the VA, because that's where we've had our experience. The same rules that apply to the VA apply to community OTPs as well. Although I think the VA at least has the added benefit of we don't really have to deal with Medicare or any of those kind of external factors that may influence specific, extra billable services. So there may be differences in, requirements in that way, but, in general, the medical care is going to still be, there's going to be minimum standards and things like that. But that was the last slide.
Great. Well, thank you very much, Dr. Snyder and Erin. It was, I hope, very informative for our group. One thing I'll add, I just came here from the University of New Mexico, and we had a very large addiction and substance use treatment program with a patient census of about 900. Most of those patients were methadone patients, some on buprenorphine, and then we had some other methamphetamine and alcohol use disorder. But we started out as methadone treatment program, so that's why we were so large. And a lot of these regulations, are really old and have a bit of that moralistic, vibe to it from, when substance use disorders were, previously conceptualized as, a moral problem rather than a health problem, chronic health problem. And so we were able to test this during COVID, when all the regulations were released and we were, dropping off 2 and 4 weeks worth of methadone doses to patients and things. And we're just analyzing that data right now, but we have no adverse outcomes for it. So I know within the field, there's a lot of pressure for the federal government to change some of these regulations to remove a barrier to treatment for these patients. So, I really appreciate all your thoroughness and going through everything that's required for this. It's life-saving care.
For sure. 100%. And I appreciate everybody that came to listen. I mean, to have that desire to learn about it. So
yeah, it's great. Well, excellent. Thank you both very much.
thank you.
All right. Have a great weekend.
All right. You too.
Bye-bye.
Bye.